share our data at this meeting about the CAR T cell studies from the group at the University of Washington, and there were several nice laboratory papers from the group at the University of Pennsylvania, and the results of that look promising, particularly for the patients who have progressed through ibrutinib, where you're sort of coming up, well, do I send this 70-year-old to transplant, an allotransplant, or do I send this patient to CAR T cells? And hopefully, unfortunately, all the excitement with these drugs in ALL and lymphoma, the CLL doctors are sort of that have these patients are sort of feeling there's less access to these trials, but it's hopefully the studies are going to open, and we'll be able to move forward with testing these to see if they have the same.
Well, certainly, I think
results.
One of the areas where we saw initial remarkable success was actually in the context of low-grade lymphoma and CLL. Cameron Turtle is presenting an abstract at this meeting looking at 18 patients with CLL, and in fact 13 of those patients were either intolerant or had failed ibrutinib, and there was really about a 77% overall response rate in the overall group, and the responses in patients who were ibrutinib either intolerant or failures was really about the same. There are real toxicities, I think, with these therapies, and the composition of the cells and the approaches may matter. In that abstract, there were balanced CD4 and CD8 infusions, and again, how the cells are expanded, how they're enriched, this may matter. And we also think that there are probably disease-oriented risk factors. We seem to see higher rates of neurotoxicity in the context of ALL than we do in the setting of B-cell lymphomas. So I actually think that we're more likely to see, as we'll talk about later, approval in B-cell lymphomas first. But I agree with you. I'd like to see more research in CLL patients with CAR T-cell therapies.
I think perhaps we ought to think seriously about the fact that the other curative therapy is allogeneic stem cell transplant, and that with the mini transplants you can do it in patients up to mid-70s now, and that they end up with some chronic GVH, but if we use the CAR T cells, that means all the B cells are gone, and they're going to have monthly infusions of gamma globulin for the rest of their life, etc. So that.
Well, I appreciate your mentioning that, Michael. As an allogeneic transplanter, I rarely now see any patients who are actually even referred for CLL, even when they're young patients who've failed multiple lines of therapy. That the same is actually true for follicular lymphoma as well. So I think that is a therapy that I would like people to actually realize especially when they have younger patients who failed multiple lines of therapy, to realize that the early treatment-related morbidity mortality is quite low, and we clearly can cure patients.
I think one of the nice things of the targeted therapies that we have, ibrutinib, 85% of them will have, a mutation similar to the T315 and CML, where these therapies are going to fail, and you can identify that 9 to 12 months before, so you have the patient at the status of MRD. They have a small amount of disease, but they're not in forward relapse where transplant doesn't work. And it's one of the few things now with the ability to do haplotransplants, I've been very impressed over the past year or two that really it's not an issue of finding a donor. If somebody has a child, you talk about a generous donor, a child wanting to being able to give back to their parent for something like that. It's a special thing.
One of the real remarkable things in allogeneic transplantations, we've seen convergence of results really almost to the point where match-unrelated donor transplants have similar transplant outcomes to sibling transplants, and now we're seeing this convergence between even cord blood transplants and haploidentical transplants. Yeah. So I think it is a great time, because and I do think that it's important as we think about these novel therapies that again, approaches like allogeneic transplant still remain for us.
Yeah, and I think the idea of whether the CAR T, for example, is a bridge to transplant or replacement for transplant, or is transplant a bridge to CAR T or replacement for CAR T, those are the major issues in this. Yeah.
I agree. Well, this is a really wonderful discussion about CLL.